Good morning, Masi. I'm just going to give 2 more minutes for members to join.
Noted, Chairperson.
Good morning, Chair.
Good morning, Deputy Minister. Are you well?
I'm fine, thanks. And how are you? I've just come from the airport, so I'm on my way. So you'll just hear, sounds and all these things. But yeah, I'm here, and the chairperson of James and the team is also. I hope they've also joined Dr. Tutu and them. Minister can be with us. There's a cabinet meeting now. It started in the morning around 8:30.
What's new?
Thank you, Deputy Minister. That's noted. We will start the meeting in just 1 minute. I just want to see that the last members join. But thank you for that. I appreciate it. And safe travels.
He's never with us, the minister.
Good morning, Masi. Are we co-rated? Can you confirm that we can proceed with the meeting?
Yes, Chairperson. Good morning to you. Yes, we can proceed, Chair. Thank you so much.
Thank you very much. Members of the Portfolio Committee of Public Service and Administration, a very good morning to all members. I would like to just also extend a welcome to the representative from GEMS, to the Deputy Minister, as well as to any other members that are joining us today. We also have today Honourable Faith Mtambi joining us, who's the chairperson of the Health Portfolio. Members, as you know, any member of Parliament can join any committee meeting. So I just thought I would just extend to her a welcome as well. Obviously, the Health Portfolio has an interest in the affairs of GEMS, so I say to her that she is most welcome to join. Members, before we do the opening remarks, can I just ask that we flight the agenda and adopt the agenda for the day? There you go, members. As you can see, we are scheduled to run today from 10 o'clock until 1 o'clock. We only have GEMS on our agenda at item number 3, the oversight over the GEMS quarterly performance and accountability for the January to June 26, so the first half of this year. And also, GEMS will be talking to us about the strategies for detecting and preventing fraud and waste to reduce medical aid expenditure by GEMS. Honourable Pulwane, I see your hand. Would you like to move for the adoption of the agenda?
Thanks for the opportunity, Chair. Good morning, everyone, and good morning, Chair. I move for the adoption of the agenda. Thanks.
Thank you very much. Much appreciated. Honourable Langa, I think your hand went up next. Would you like to second?
Good morning, Chair. Good morning to GEMS and to PSA. Yes, Chair, I second the adoption of the agenda. Thank you very much.
Thank you so much, Honourable Langa. Much appreciated. Members, with that, our agenda for the day has been duly adopted, and we can now move on to the apologies. Members, I would just like to quickly check the apologies that I received. I've got down Honourable Gondwe. Honourable Gondwe is a new alternative member on the committee, but she has put in an apology for today, as well as Honourable Spies and Minister Buthelezi. So those are the 3 apologies that I have received and that we can note. But members, or staff, is there any other apologies to be noted? Honourable Langa?
Thank you, Chair. I just wanted to check an alternate member for which party? Thank you.
Yes, so it's Honorable Mimi Gondwe, and she is from the Democratic Alliance, and she has recently joined us as an alternative member on the committee.
Thank you, Chair.
It's a pleasure. Of course, when she attends her first meeting, I will just introduce her as well at that stage. Members, if there are no other apologies to note, I think we can then move on to the next agenda item. Members, the Money Bills Amendment Procedure and Related Matters Act 2009 requires committees of Parliament to conduct regular reviews of both the financial and the non-financial performance of the respective departments and entities, and where necessary to make recommendations regarding the use and allocation of resources. We are quite aware that GEMS is not funded by the fiscus, but funded through member contributions and employer government contributions. However, since GEMS was created through an act of parliament, we have the constitutional mandate to conduct oversight over the entity on its governance. But without further delay, I would just like to give Honourable Deputy Minister Kekane an opportunity to provide some opening remarks on the performance highlights and gems, and then we can allow the presentation after that. Deputy Minister, would you like to say some words?
Thank you, Honorable Chair, and let me also acknowledge Honorable Chair of the Health Portfolio, Honorable Faith Mutambi, and all honorable members in the Portfolio Committee. And as I said, the chairperson of GEMS, Dr. Tutu, is leading the team from GEMS to take the Portfolio Committee through on the journey we have traveled from January until now. And Honorable Chair will remember that the accountability activities of GEMS have since been ignited during the 7th administration. And at least ever since we introduced that through you in Parliament, they are now moving up to speed to keep up with what Parliament expect. So that's the first thing. The second issue is that um, the chairperson will also take the committee through. The principal officer of GEMS is on suspension. GEMS falls under Minister Buthelez's portfolio, but I was also made aware when that action was taken, and I think they are still undergoing the investigations with regard to that. The third issue is that we are now going towards the new approach into how the increases and other related matters on the medical aid are concerned. And I think the commitment we made to the portfolio committee is that whenever that happens, James will reach out not only to us as the department, but also engage with trade unions and members to say, this is the approach by the administrator, and how do we deal with that, as the regulator will be expecting some of those things. So those are some of the things that the chair will highlight as they give full account on what they have been going through and how best do they deal with issues of fraud, and also eliminating the porosity in the portfolio. So with your permission, Chair, allow me to call in Dr. Tutu to come through, and then he will introduce the acting person and then be able to take the portfolio committee through. Thank you.
Thank you very much, Deputy Minister. It's much appreciated. and I align myself with your comments. Members, we then now move to item number 3, and indeed Dr. Dudu, who will be leading the GEMS delegation and who can introduce the different members of her team so that we can have the presentation. GEMS, over to you.
Thank you so much, Honorable Chairperson. Honorable Chairperson, Mr. De Villiers, Honorable Minister Buthelezi in his absence, Honorable members of the Portfolio Committee, well, Honorable Deputy Minister, Ms. Pinky Kekana, then Honorable members of the Portfolio Committee, and then Honorable Chairperson of the Portfolio Committee on Health, Ms. Faith Mutambi, senior officials of the Department of Public Service and Administration, ladies and gentlemen, and also I also want to greet our the executives that are accompanying me in this portfolio committee. Ladies and gentlemen, on behalf of the Board of Trustees and the executive management, thank you for the opportunity to engage with the committee today. As the Deputy Minister has indicated, the principal officer has been put on suspension, and I appreciate DM or the time that you've taken to indicate that our principal officer has been put on suspension. However, the matter is still being investigated. We will update the portfolio committee and the office of the minister of the developments that will ensue following the investigation. But at this stage, the matter is being investigated, and we do not have just to protect the integrity of the investigation. We will end up there at the moment, and then but we'll update the portfolio committee as the matter unfold. We welcome the Parliament's oversight role and the opportunity to account for our stewardship of the healthcare contributions entrusted to GEMS by government employees and their families. We also acknowledge the Minister's leadership in advancing an effective and capable public service. GEMS remains committed to providing affordable, quality healthcare to public servants while maintaining strong governance, accountability, and financial sustainability. The board continues to oversee the performance, financial management, risk, compliance, and governance, ensuring that challenges are addressed and corrective actions are implemented when necessary. Protecting member funds remains our key priority. We continue to strengthen fraud prevention, monitoring, and risk management measures to reduce the losses, improve efficiency, and safeguard the scheme's resources. At the same time, we remain mindful of the financial pressures facing public servants and strive to balance affordability, access to quality healthcare, and long-term sustainability of the scheme. We value the constructive engagement with Parliament and then the other stakeholders, and as it strengthens accountability, transparency, and confidence in the scheme. We look forward to engaging with the committee on our performance for the period from January to June, and as well as measures implemented to prevent fraud, waste, and abuse, and reduce waste as well. Chairperson, I am with executive members of GEMS, and I'm going to now invite them to please introduce themselves on this platform. With your permission, Chairperson, I'm going to hand back to you for the GEMS members executives to introduce themselves so that they can take the committee through the presentation that we have prepared. Thank you, Chairperson.
Thank you very much. Much appreciated, Dr. Tutu. The rest of the delegation can proceed.
Good morning, Chairperson. I hope you can hear me. Good morning. I would like to greet the Honorable Chair, De Villiers, the Honorable Chair Mutambi of the Health Portfolio, honorable members of this committee, and the Honorable Deputy Minister, good morning. My name is Dr. Vuyo Kola. I am the Chief Operations Officer of GEMS, and I'm also acting as the Principal Officer. I am going to ask my colleagues to, before we start the presentation, Chair, to just switch on their videos and introduce themselves. Thank you.
Good morning, Chairperson and colleagues, portfolio committee members, Chairperson of the board and Chairperson of the Health Committee. My name is Karina van Lingen. I am the Chief Financial Officer at GEMS.
Good morning, Chairperson. All protocol observed. My name is Andre Cowley. I'm the Chief Compliance Officer, and fraud, waste and abuse falls in my portfolio. I also want to introduce Mr. Ishmael Mohapi, Senior Manager, Fraud, Waste and Abuse, who will be assisting me in the presentation. Thank you.
Good morning, Chairperson, members of the Portfolio Committee, all protocol observed. My name is Masingita Chabalala. I'm the Chief Strategy Officer at GEMS.
Thank you, Chairperson. Those are the colleagues that will be presenting along with me. If I may start, Chair.
Maybe before you start, Dr. Vuyo, let me also open my camera so that I can show my face, and then I'll switch it off quickly. That's my face. I think the light is actually blurring the vision, but that's Dr. Tutu, the chairperson. Thank you. Dr. Vuyo, over to you.
Thank you, Dr. Tutu. Thank you, Chairperson. Through you, if I may start the presentation. Chair, as you did mention when you opened that the intention of today's meeting or presentation from GEMS rather is to present the update in terms of the performance from January to June of 2026. I'm just going to ask my colleague David to please move the slides to the next slide. And then, Chair, we will be covering the main areas, which are the pertinent matters briefly. Then we'll go into the financial performance as well as performance against our annual performance plan. And then Mr. Cowley and Mr. Mohapi will then finish off with the strategies towards fraud, waste, and abuse. Next slide, please, David. So on the pertinent matters, David, if you could just, it looks like there is a bar that's blocking the slides on the far right. If you could just minimize that, thank you. I hope that's visible now. So at a glance, Chairperson, as of the end of June 2026, we have a total of 897,000 main members or principal members that have been registered with the scheme. Inclusive of beneficiaries, then we cover a total of just over 2.4 million lives at GEMS. The graph on the right just shows the increase of GEMS in the last 4 years from 2023 to 2026. The incremental increase particularly in 2023, 2024 and 2025. In 2026, the growth has been stable. We have not had too much disruption in terms of the growth. As far as the net contributions that we've collected up until end of June, we've collected net contributions of 36 billion, and claims that we have paid are just over 34 billion. So we have paid claims that are less than what we've collected in contributions so far, and we're hoping to see this positive trend going into the next half of the year. Our reserve ratio is at 22.57% as of the end of June. This is below the statutory requirement of 25%. However, I will say that we have a business plan that is submitted to the Council of Medical Schemes with regards to how we will go back to the 25% reserve ratio in the next 3 years. Our non-healthcare expenditure, meaning claims that we pay that are not related to healthcare, such as head office budget, outsourced services, administration, and staff, remains lowest, one of the lowest in the industry at just 5% of our net income. And the next slide, David. Chair, with regards to the member contributions for 2026, GEMS did announce an increase, a weighted increase of 9.8%. That was effective as of the 1st of January 2026. However, through engagements with organized labor, this was later revised to 9.5%, which started on the 1st of February 2026. Through our engagements with labor as well as the ministry, we further proposed a reduction in the contribution increases of 7.5%, which was submitted to the to the Council of Medical Schemes. The intention was that this would be effective as of the 1st of July 2026. As we are regulated by the Council of Medical Schemes, any changes in contribution increases or benefit design have to be submitted. The regulator then felt that it was not in the scheme's best interest from a financial point of view to further reduce the contributions. So this was rejected or not approved by the regulator. So we remain at the 9.5 contribution increase for 2026. With regards to just the lower contribution table, just go back a little bit. The lower contribution tables at the bottom there, Chair, that just shows per family for each of the various options at GEMS, the average contribution of the members based on their. As you can see, GEMS has a income-based contribution bands, so members pay based on their income levels, and this just shows what the average contribution is before subsidy for various families. Thank you, Chair. Next slide, David. So, Chair, this just elaborates a little bit further with regards to what I mentioned before, with regards regarding the submission to the medical scheme, where the registrar did not approve the proposed further reduction to 7.5% for 2026. And the reasons that were stated is that the reduction in the contribution might not meet the level required to meet the expected or unexpected scheme costs. As we know, the healthcare costs are continuously raising, and medical inflation is above health inflation, and there's issues about utilization, growing burden of disease, as well as fraud, waste, and abuse that will be presented on earlier. So the regulator felt that he was not comfortable with further reduction on this. He also stated that this would lead to ongoing operating deficits, and that the delay in the compliance, meaning the recovery back to 25%, would then be further projected to 2030 if that 7.5 is applied. As I had mentioned, Chair, that we do have a business plan in terms of going back to the statutory 25%, and the regulator felt that the 7.5 reduction would then just delay that projected recovery back to the statutory reserve. He also felt that there was material reliance on an uncertain future. This is in regards to the claims expenditure and the fact that the scheme had also included the projected savings from a claims management perspective. However, these were not realized and therefore would pose a risk if these would not be realized. So these were the reasons in short, Chair. Next slide, David. There's further initiatives that GEMS has undertaken, Chair, to just make sure that while we do not want to restrict access to care, we need to make sure that we manage claims that are eroding the scheme's benefits, that are eroding the scheme's reserves, but making sure that we still adequately provide access to care and we pay for care that is required by our members. And this has been done through carefully reconsidering a benefit design strategy. There's also a claims management forum that is aimed at managing the increased utilization and the wastage that happens. There's also several initiatives that my colleagues would go into with regards to fraud, waste, and abuse. Starting at head office and all through the operating costs at GEMS, we have focused on further reduction of that 5% of the non-healthcare costs expenditure by decreasing even our own expenditure internally. There's active disease risk management with regards to members on the chronic disease, and there's also a strong focus on preventative care as well as wellness, just to make sure that our members remain healthy, because healthier members claim less and they're more productive as well. Next slide, David. I am going to hand over to the CFO to take us through the performance plan. Chair, Karen, over to you.
Thanks, Vuyo. This is Masi's part. So Masingita, please go ahead.
Apologies, Masi. Over to you.
No, that's fine. Thank you, Dr. Vuyo. Thank you, Karina. Good morning again, Chairperson and everyone around the room. I will be taking the Portfolio Committee through our annual performance plan. This slide just depicts GEMS alignment with Program 3 of the DPSA APP, where it focuses on improving the health and welfare of public servants to create an enabling environment for productivity. So DPSA strategic plan highlights the improvement of health and welfare of public servants as a critical enabler of productivity, morale, and service excellence. It is also responsible for making the public service employer of choice and to provision of accessible healthcare service. And as GEMS, we continue to execute our mandate aligning to Program 3, and as we directly operationalize these objectives by providing affordable, accessible, and comprehensive medical cover to government employees, supporting both physical and mental wellness. GEMS is a strategic health and wellness partner to DPSA, reinforcing again Program 3's goals on labor peace, productivity, and fair conditions of service, as we contribute to strengthening public service delivery through a healthier, more secure workforce. Again, just to emphasize the wellness management program that GEMS runs, including chronic disease management programs, mental health support, preventative care screening, and mental health initiatives, just to ensure that public servants are fit, present, and are able to perform at their best, aligning directly to the DPA's productivity objectives. From a performance perspective, Chair, the scheme overall tracks and monitors 43 key performance indicators through the 2026 board-approved annual performance plan. Of the 43, 17 are directly aligned to Program 3 objectives of DPSA. At the end of Q2, which is June 2026, because the scheme's financial year starts in January. So by the end of Q2, June 2026, we had 17 key performance indicators, and 9 that of the 17 rather of the key performance indicators, 9 were achieved, 4, which is 24%, were not achieved, another 4, which is 24%, were not due for reporting. Overall, in terms of the last slide, we are just showing that broadly with all the 43 KPIs, by end of Q2, we were sitting at 58%. Next slide, David. On this slide, Chair, we are going to go into a lot more detail just to highlight the various KPIs aligned to Program 3 of DPSA. The first one talks to stakeholder satisfaction. where we measure 3 KPIs. The first one being the 2026 industry average minus 0.5. On this specific KPI, this is an industry-initiated survey where a service provider, an independent service provider, assesses the industry in terms of performance for a various number of disciplines. We track the healthcare industry in terms of how we compare to other players in the same industry. These results are available in Q3 and analyzed to be able to be reported in Q4. The second KPI is a GEMS initiated member satisfaction survey. Our target for 2026 is 85%. We do see that for both Q1 and Q2, we did not manage to meet the target. Q1 sitting at 71%, Q2 sitting at 73%. Noting the fact that this is one of the critical surveys where we get to understand member sentiments in terms of the experience that they have with GEMS, the emotional connection that they have with GEMS, and some of the operational discomfort and inefficiencies that they are experiencing. Some of the initiatives that we are bringing into this space is to analyze the surveys in detail, understand where the gaps are, where the pain points are. We also have what we call a service management forum, where together with our service providers, we go into detail analyzing these results to be able to come up with initiatives to improve the member satisfaction. The third one that we track, David, if you can go back. The third one that we track is the healthcare provider satisfaction survey. Again, it's an 85% target. We are also picking up that for both quarters, we did not meet the target. 80% in Q1 against the 85% target. 82% where we saw a slight improvement against the 85%. Again, we have what we call our provider liaison office, which is established to focus a lot more on direct engagement with our providers to understand some of the issues that are on the ground that the providers are experiencing, because this is an area that we take as a priority because these are the providers that service our members, and by virtue of that, we don't want their frustrations to translate into member frustrations. So through our provider liaison office, we are engaging to understand where the pain points are and what the service is saying to be able to come up with initiatives to improve. From a priority stakeholder perspective, this is an KPI where we have identified various priority stakeholders across the GEMS landscape. The first 2 quarters has been to analyze the historical experiences that we've been experiencing with the stakeholders, and that is why you would see chairperson, it is not due for reporting, and then our target is to look at engaging at 75% out of the 10 that would have been identified. The idea around this is to also understand from an outcome perspective, what is it that we want to be able to get out of the engagements that we have with priority stakeholders, not to simply just engage, but have a prior understanding of what we want to get from each stakeholder so that the engagements are more effective and productive, and any initiatives and recommendations are considered as we execute our strategy. The last one on this slide is our administrative efficiency. Our target is 90%. Here we talk about how we are efficient in the execution of GEMS through our administration services and our managed care services. We do see that from a performance perspective, we have been doing quite well against the 90% target. However, we do still dig a little bit deeper to understand how else we can just ensure that we improve. Next slide, David. On this slide, Chair, I will just go through high level. Our CFO has a couple of slides that will go into detail in explaining our financial targets. From a reserve ratio perspective, our target is 21.72%. In Q1 and Q2, we did manage to perform against the budget. When our COO and acting PO started with the presentation, she also highlighted the fact that from a statutory requirement perspective, we do require we do require a 25% reserve ratio as required by the Council for Medical Schemes. However, the presentation that is provided here is based on what was budgeted for and the budget that was submitted to CMS. Our CFO will explain in detail in terms of the rationale behind the budget that was submitted. From an investment perspective, we see that the performance has been quite stable, and we're seeing an increase as we move forward, and we're definitely looking forward to Q3 and Q4 in maintaining the reserves. From an investment income perspective, in Q1 we did see a target that was less. Performance that was less than target, but we then recovered in Q2 against target, where we see a 610 billion against the 503, 500. Numbers always get me, billion. But the overall point here is that we are recovering, and we look forward to again progressing quite positively in this specific KPI. Our claims ratio target is 6.5%. Target for Q1 was 97.8. We did outperform that target, 97.8, and then the target for Q2 is 97%, where we also see a 97.85%, which is a positive trajectory, looking at how we measure the claims ratio, where we want to see a reduction in claims. Percentage of non-healthcare cost, our target is 6%. We are seeing that for both quarters we have met and performed against target. Next slide, David. In terms of the strategic objective 3, we measure the compelling value of proposition of our products, where we've got 3 KPIs. The first KPI, we look at the average percentage of product availability. Our target for 2026 is 23%. For first quarter, second quarter, and third quarter, this target is not due for reporting. The information that informs the calculation of this target is received in Q4 after all the medical schemes in the country have announced their contribution increases. This is where we compile the information and do an average analysis against our own increases to see how we actually compare against what is happening in the industry. So this information is only available after Q3, and our target for this year is 23%. If we look at the increase in hospital rate relative to the previous year, our target is 2.3%. We do see that for both quarters, we have outperformed our target, which is also linked to the information that was provided by the COO in terms of the initiatives that we're driving around claims containment and some of the preventative care that we implement to ensure that we minimize the hospital admission rate. From a percentage of out-of-pocket, this is an area where members experience out-of-pocket when they receive service from GEMS. We do see from a target perspective for both quarters, we are finding ourselves a bit short. Our target is 5.7. Q1, we performed at 6%, and Q2, we're performing at 5.83%. Some of the things that we are looking at in terms of mitigating and returning back to target is just engagement with members and providers around education on some of the initiatives that they can think of. Some of examples would be generic medication. The use of generic medication can also help reduce out-of-pocket for members, and also looking at medicine formularies, engaging the pharmaceutical industry to see how else we can actually do negotiate better on the medical formularies. Also looking at hospital services, how to manage unnecessary charges, working together with the fraud, waste and abuse team on how we can proactively manage this space. The next target, or KRA rather, is clinical risk indicators. The first KPI that we measure, Chair, is the percentage of healthcare quality outcomes above the industry average. which is a report that is determined by the Health Quality Assessment Matrix. Our target for 2026 is 50%. This is one of those targets that's also not due for reporting. It is informed by industry performance, and as soon as the report is produced in Q4, that is where we'll be able to understand where we land in line against our 50% target. The last one is the achievement of the World Health Organization HIV targets, which is 95, 95, 95. The first 95 talks to knowing your status. The second 95 talks to, as soon as you know your status, to be on medication. And then the last 95 talks about how a viral suppression, where the viral load is undetectable. From a target perspective, we do see that the first 95 for both quarters, we have performed quite well. The area that we need to push a little bit more from a GEMS perspective in terms of education is the issue around medication that is available for those that have tested positive for HIV. For both quarters, we see that we landed at 93.7, and then the second quarter 93.8. So there are initiatives to drive education around the availability of medication to be able to respond to those that have tested positive for HIV. But for knowing the status and the target around viral load suppression, rather, we have exceeded the World Health Organization target. Next slide. So this is the last KRA that I will be talking to Chair, where we're looking at the sustainable membership growth across the 2 quarters. The first KPI that we look at is the number of members registered at the scheme. Our target for this year is 893,000, 893, just over 893,000. Target for Q1, which we've determined progressive targets towards the end of Q4, it's 894,000, and then actual is 896, and for Q2, 897,000. We see that from a registering of new members, we are seeing a positive growth towards members joining GEMS as members join the public service. Another one that we track is the percentage of member retention, where we're looking at how well we're actually retaining members in the GEMS environment. We do see that from a percentage perspective, we have performed quite well for both Q1 and Q2, which in our view demonstrates our approach to the way we engage members on the benefit of being on a medical scheme, as in this case, especially GEMS. Overall, Chair, from a APP performance perspective, we do see that there has been positive progression in a number of KPIs. Where we do find ourselves short, initiatives have been put in place for us to be able to recover in Q3 and Q4 to ensure that we continue to service our members effectively. Thank you, David. Thank you, Chair.
Thank you, Mercy. Chair, I'm going to proceed with the financial performance slides for GEMS. So the first one we are looking at is the statement of profit and loss. So what we've shown here is the 6 months results up until the end of June, which we compare to the previous financial year. And it's really to give a sense of mid-year this year, where is the scheme, and to illustrate that if you look even at the bottom line, that the scheme is already in a better financial position than what we were at the end of the previous financial year. Next slide, please, David. Also, in terms of the statement of financial position, mid-year we can confirm that the financial sustainability and financial position of the scheme is stable compared to the prior financial year and heading towards the end of this financial year. Next slide, please. So some of the key ratios that we measure to make sure that we keep track of important indicators. First is the reserve ratio that Dr. Vuyo has spoken to. I will speak to that in a bit more detail in the following slides. We are at 27.8%, lower than last year, and this is really as a consequence of many factors, one being the way the formula is applied in the beginning of the year, and secondly, we do know that we are building up reserves back to the 25%, but I will speak to that a bit more. The liquidity ratio is important. It shows the ability of the scheme to pay claims and other liabilities as they become due. So currently we are standing at a 3.78. The norm measured usually is 2, so we are above the norm of a very strong liquidity position for the scheme at the moment. The return on investment, Masi has spoken somewhat to that. That is the returns that we have been recording on our investments that we have, where we invest members' funds. And as you can see, very high, very good investment returns. So we make sure that the funds are appropriately invested and gives back to the members appropriate returns. The claims ratio has also been spoken to. So this is the measure that we measure how much of your contributions we pay out in claims. And as we can see, a good improvement from the previous financial year. I'll speak to that a bit more also, because this was one of the significant challenges that we faced in the previous 2 financial years that tapped into our reserves. So currently at 96.9%, essentially you would want your claims ratio to be in the region of anything between 90 and 95%. Non-healthcare costs at 5%, as Dr. Vuyo also mentioned, one of the lowest in the industry. What that really means is for every 100 Rand in contribution paid by a member, only 5 Rand of the 100 Rand is used for administration and running the scheme. The other 95 Rand is utilized and paid for healthcare services for the member. Next slide, please. So this slide is to illustrate to the committee how we used reserves over the previous financial year, and that is really what drove the reserves to below 25%. And the scheme has been in a recovery state in the last 2 financial years, and this year being the 3rd and hopefully the last year where recovery is implemented. So in the COVID years, GEMS in 2022 and 2023 decided to implement very low contributions, and this was deliberately done. This was done to support members, to make sure affordability. A lot of people and their families went through difficult economic times, and that was done to support members to that extent. So during that period, you can see from the graph, the scheme used 10 billion Rand in reserves to give back to members, to support members. Now, the consequence of doing that over time is that one has to correct for the lower than inflation increases in future. And therefore, the 9.5% and the 13.4% increases in subsequent years. So once the reserves are tapped into, it has a downward projection. And it is really to get out of that downward projection that the scheme is currently in. And Dr. Vuyo has mentioned that this is the business plan we have in place with the Council for Medical Scheme. And this is to ensure that we get back to the statutory requirement of 25%. I do want to state, though, that this does not mean that the scheme is in financial trouble. It does not mean that the scheme is financially unsustainable. It is merely an indication that we need to intervene and ensure that reserves don't fall further below where we are, so that we ensure in future that the scheme remains sustainable. Next slide. So the reserve ratio recovery and the financial sustainability, I think this is the last part of the reserves that I will comment on. So currently the recovery work that is underway shows us that claim costs are lower than budget, and I will show that in a moment. The benefit design changes that we introduced, particularly in this year, are producing savings. Managed care interventions are improving the utilization, which was a concern in the previous 2 financial years. Non-healthcare expenses are still well managed. Member funds are currently more than what we expected it to be at this point in time. And our projected results for the year end is better than what was anticipated. So we have some key interventions that we implemented through a claims management forum that started in the previous financial year. Some of those we've listed here. It includes additional hospital authorizations, the introduction of hospital networks, streamlining case management, ongoing managed care interventions, and provider engagement initiatives. And all of these, we are seeing positive results coming through in the numbers, which I'll show in a moment. So in terms of financial sustainability, James, as I've mentioned, remains financially stable. We are able to meet all of our obligations. The reserves are gradually being rebuilt back to the 25%, and the long-term sustainability depends on our cost containment, our managed care savings, and future surpluses. And the aim is by 2029, at the latest 2030, to be in that position. And I will also show the numbers in terms of that. Next slide, please, David. So in terms of our expectation towards the end of the year, it's always good to know where you are now. But if we look forward to the end of the year, and with the assistance of our actuaries, we have projected. You will see the middle column of this slide is the projection towards year end. And you will see if we just focus on the bottom line, we are already expecting that the end of the year's reserves is about 1% better than what we had initially budgeted for. And it is an indication of the work that we've implemented, the intervention processes that are in place to manage the claims and the containment of claims, so that we can recover to our reserves faster and manage the claims to expectations. Next slide, please. So what does this mean for the next 3 to 4 financial years? So as I've mentioned, for 2026, our reserve ratio projection end of year is about 23.5%. So looking into the future with the assumptions that we've listed at the bottom of the slide, the reserves will steadily increase and move back to 25% by the latest in 2030. These are all subject, of course, to those assumptions made, and the scheme is ensuring and managing that particularly the claim costs are managed to ensure that these projections can materialize into the future. You'll see that at the bottom also we do expect in this year to save 1 billion rand in terms of the claims management interventions that we have implemented. Next slide, please. So healthcare costs, we have indicated this is the claims ratio. If you look at the industry, which is the yellow line, James, in the last 2 to 3 financial years were way above industry norms. And we reported this previously, the excessive utilization that we saw in our space with our members. And therefore, with the interventions, one can now see towards 2025 and to mid-year this year that the claims experience is coming back to industry levels, which is more acceptable and appropriate to where we should be. Next slide. So hospital admissions is one of our largest cost drivers. Significant proportion of claims that we pay comprises of hospital admissions. It's therefore important that we ensure and monitor hospital admissions throughout the year and every option. What is noteworthy is the changes implemented to Tanzanite 1 has provided a reduction in hospital admission rates, which is a good indication because there was a belief that there was abuse in terms of this low-cost option that was created specifically for low-income members. Next slide, please. So we have a number of hospital cost drivers that we have been managing. In the previous financial year, there was a significant concern around the in-hospital professional fees, which currently has only a 2.1% change from the previous year. However, in the previous 2 financial years, this was a big concern. These numbers were in excess of about 18% increases. Next slide, please, David. So if you break that down into a bit more detail in terms of what specific disciplines drove that, we saw that pathology, radiology, clinical technology, some of these areas or disciplines were the main drivers. And those are the areas where we have focused and implemented these interventions that we are now seeing is providing good results for the scheme this year. Next slide. And this is really to illustrate that. So with the interventions that we've implemented, you can see the downward trend in the claims experience that we show here from Q1 to Q2, and we do expect Q3 and 4 to continue on this trend. And this is evidence of the work that's being done to ensure that claims are within acceptable levels. Next slide. We also like to share some of the good stories where GEMS does really pay for members in need of healthcare, in particular, those events that no one foresees that will cross your road. We also report this in our annual integrated report. So for this purpose, we've on the right-hand side indicated 5 members. Where for an individual, let's just take the first one, claimant A, in January as an example, where the scheme has paid 5 million rand for one member that needed healthcare cover. And I think these are the good stories we can tell where GEMS really does step up when members are in need of their medical scheme. On the left-hand side, what we show is just the typical proportion of claimants in any particular medical scheme. So the majority of your claimants will claim less than 100,000, and then a small proportion of members, currently about 5.6%, that claim in excess of 100,000. And if you think in relation to your monthly contribution, this shows the importance of having medical cover in those instances. Next slide. So just an illustration, I've spoken a lot about the interventions that we've implemented. We are tracking these specific interventions. They were target set, and then the actual savings coming through. So it's just an illustration of how we are monitoring this and ensuring that we continue to manage the interventions so as to achieve the R1 billion target that we had set for the end of the year. Next slide. So non-healthcare costs, there's always this question around head office costs, salaries paid. So what we're trying to illustrate here, and you will recall that I mentioned our non-healthcare cost is only 5% or 5 rand for each 100 rand in contributions. And if you look to the right-hand side on the pie graph, you will note that the largest proportion of our non-healthcare costs consists of what we pay to our SPN or our service provider network. So this is our administrator and our managed care organization that deliver those services on behalf of GEMS. And a very small proportion, the blue part, is in relation to what we use at head office and what we pay our staff members and some professional fees. Next slide. I think we can skip this. We've spoken to that one. Just to show a comparison to the industry, we've mentioned that we are one of the lowest non-healthcare costs in the industry. So on this slide, we've done an exercise to show in relation to Bestmed, Bonitas, Discovery, MediHelp, MedShield, PaulMed, and Transmed. You will note GEMS on the left-hand side is one of the lowest. So GEMS and PaulMed in the industry are the schemes with the lowest non-healthcare costs. So the majority of your contribution is paid towards healthcare. Next slide. So contribution comparison, we thought it necessary just to also show this to the committee, as there's been a lot of debate and discussions around the contribution increases of GEMS. So if we look, what the slide illustrates is just over the last 5 years, 6 years, from 2019 to 2026. Again, looking at other schemes in the industry in South Africa, Discovery, Bestmed, Bonitas, FedHealth, MediHelp, MedShield, and Momentum. So on average, during the course of those 6 years, what were the contributions? And on the left-hand side, you would note that GEMS contributions on average over the last 6 years were relatively in the lower class than compared to some of the other schemes. Next slide. So an additional exercise we did, and this is just for illustration purposes, we have looked at Discovery, Bonitas, and Bestmed as examples in the industry. What members pay in terms of contributions. So on the left-hand side, we compare that to our typical families on our various options, and what they pay as a GEMS contribution for those families on those options. And this illustration is just for the first or the lowest income band. We've done this for all of the bands, but we are just showing this one for illustration. So a member on the lowest income band on GEMS, if they had to go to Discovery, on average, on any option in GEMS, on average, they would pay 20% more in contributions. On Bonitas, they would on average pay 33% more, and on Bestmed, 43% more. And these numbers are before the subsidy is considered. So if you for a moment don't consider the subsidy, if a member had to move out of GEMS today into the market and get other medical cover, essentially on average, they will pay between 20 and 40% more. Next slide. Oh, that's the end of mine. I'm going to hand over to Andre now for fraud, waste and abuse. Thank you, Chair.
Thank you, Chair. We can move to the next slide. Firstly, I have to say that fraud, waste and abuse is commonly acknowledged in industry as a substantial problem. Depending on which source you use, anything between 15 and 25% of contributions in medical aids are deemed to be fraud, waste and abuse. If one looks at GEMS at a contribution income of around 60 billion rand, it's clear to see there's a substantial amount of potentially up to 10 billion rand that can be attributed to fraud, waste and abuse. Now, the question is how industry and specifically GEMS tackles this important impediment so that we can put that money back in a member's pocket. Every rand that we save on fraud, waste and abuse will directly reduce member contributions. So GEMS would look at this from a three-prong approach. We've got three distinct strategies to curb fraud, waste and abuse. Strategy 1 talks about prevention, detection, number 2, and then lastly, remediation and recovery. In the first strategy to prevent fraud, waste and abuse, the scheme believes that education of members providers, and also through professional societies and bodies, that education is an important instrument, so that that everyone understands the direct implication of their actions if they commit fraud, waste, and abuse, what the impact is on members, on affordability, and eventually on the industry as a whole. GEMS follows a very extensive engagement strategy to enable this sort of engagement and education. On the right-hand side, we can see that GEMS stakeholder engagements for 2025 totaled 50, and for Q1 and Q2, we can also see that we are well on track to match and exceed that target of 2025. To make this more efficient and to reach more points, GEMS is expanding its communications through the use of online and digital communications, just so that the hands of the GEMS fraud, waste and abuse team can be multiplied, and that we can reach further and more to prevent fraud, waste and abuse through education. I also want to say that when we do these engagements, after such engagements, we will always note a increase in our fraud hotline, where fraud, waste and abuse is then reported. So the awareness is definitely translating into better detection of fraud, waste and abuse. On the second strategy, detection of fraud, waste and abuse, we use a multiple set of tools, digital analytics. We use our whistleblower hotline, as well as forensic investigations. But if one looks at GEMS, that processes about 150 million claim lines, 150 million claim lines per year, one can appreciate that detecting fraud and all instances of fraud is humanly not possible, and a manual process will not yield that level of detection. So the success of detecting fraud, waste and abuse with an emphasis on early detection before the scheme pays for these false claims, we must detect it and stop payment before and not try to recover afterwards. That is the most efficient method. We can see that with the current methods that we have in 2025, more than 3,000 instances of fraud, waste and abuse were picked up through our tools. At Q1 and Q2, we can already see an improvement on the prior year, and seeing more of these detections being made. We are, however, well advanced in exploring and implementing advanced digital detection tools, artificial intelligence type of tools, and we are set on seeing the results of that in the very short term. I always compare the banking industry. The banking industry is probably one of the most advanced when it comes to fraud, waste and abuse detection. In that 1 second that one swipes a credit card, the bank does a multiplicity of checks and balances on that transaction, and in that 1 second they can detect whether there's a possibility of fraud, and that is ideally where we want to go. When a claim is submitted to GEMS, we want to be able to very quickly detect any anomalies and stop the process of payment before we actually make the payment. The last step is the remediation and recovery. Here we have three ways of recovery. Firstly is the changing in the provider errand behavior. What we do find is that if some form of detection is made and a healthcare provider is informed that some abnormal claiming patterns have been identified and which we're looking into, we see an immediate change in behavior where errand providers from the subsequent months change their claiming patterns. We also recover fraud, waste and abuse then through settlements or admissions of debt, and also recovering fraud, waste and abuse through civil proceedings and court judgments. We can see on the right hand side our performance for 2025, just about 260 million was remediated and recovered. Currently for Q1 we are already at 85 million. Q2 results are not yet available, but well on track to meet and surpass fraud, waste and abuse recovery from the prior year. GEMS is optimizing its recovery processes so that we can also deal with recoveries quickly. Then in terms of being more specific, what are the top 5 risks shaping the fraud, waste and abuse landscape? The most important thing is that perpetrators are ever changing their methods, probably very innovative, if one can use that term. So what we're currently seeing and where there is heightened areas of fraud, waste and abuse, there. Thank you, David. The provider billing for services not rendered. These claims are submitted for healthcare services, procedures and medicines that were simply not rendered. Provider member collusion. We often see that it takes 2 parties to be committing these crimes. Service providers and members collaborate and work together to submit false or even inflated claims and then afterwards share the proceeds thereof. We have seen a increase also in syndicated fraud behaviors, and this is really where multiple parties across potentially different disciplines would work together to defraud the scheme. This sort of syndicated behavior, of course, runs into multi-millions of rands that the scheme then takes action on. A common occurrence is also upcoding and procedure manipulation, and that's where billing codes, quantities, clinical details are deliberately manipulated, so reimbursement is made above a reasonable and justified level. Poor billing oversight by service providers, also where inadequate billing controls and supervisory review are not in place. Moving to the next and running into concluding this presentation, what are the emerging areas? These are areas that hasn't been around for that long, but what we are seeing increased activity, exploitation of wellness days, provider fronting, prescribed minimum benefit abuse, practice and identity hijacking, and unnecessary procedures. And some examples are listed where we are seeing increased activity. In terms of our detection, analytics and intelligence, we just indicate here that we use a broad range of methods, which includes peer group benchmarking, longitudinal profiling, provider-side anomaly detection, and member-side anomaly detection. In terms of enforcement, we also follow a variety and a spectrum of methods. Firstly, where warranted, civil and criminal actions are taken, and where court judgments are obtained for recovery of these fraud, waste, and abuse amounts. Regulatory, we also report to the professional bodies, the councils, the HPCSA, and these are referred, matched to the appropriate body. And lastly, the AOD and recovery method, where we obtain repayment commitments and we enforce these repayments on an ongoing basis. So lastly, what is the scheme doing to further enhance and accelerate our ability to detect, prevent, and remediate fraud, waste, and abuse? On the prevention side, prevention and claims integrity, we have mentioned the education of various constituents, but also prevention is obtained through implementing clinical rules, tariff controls, which prevents abuse by the inherent structures of our benefit options. Then advanced analytics and technology. I have mentioned that we are already using advanced analytics and technology, but looking to really substantially implement further leading edge technologies to assist. Focused investigations. We are applying the forensic clinical behavior intelligence to detect, investigate, and address high-risk providers. So the main theme here is to be able to use your intelligence to spot high-risk areas. Recovery and financial recoupment. We will be accelerating the recovery process through streamlined debt management and industry collaboration, strengthening partnership with regulators, law enforcement, and industry stakeholders across the board to accelerate and improve our abilities. Lastly, governance, ethics, and culture. We are looking to embed accountability, transparency, and stakeholder awareness through robust oversight and reporting mechanisms. So thereby we will accelerate our efforts through fraud prevention, early detection, effective recovery, and sustainable healthcare funding. Thank you.
Chair, we will then just conclude on these 4 points. The scheme remains in a strong financial position and continues to operate as a going concern. The scheme has implemented robust interventions to respond to the sustained pressure from utilization. The reserve ratio is projected to return back to compliance latest 2030. Healthcare costs remain well managed and below industry average for this year so far. And the scheme remains committed to its mandate of providing affordable, equitable, and comprehensive healthcare coverage for public servants. Thank you very much.
Thank you very much, execs, for the presentation. Chairperson, can I hand over back to you now? Thank you very much.
Thank you very much indeed, Dr. Tutu, and the rest of the team that assisted us with the presentation. It is welcome indeed. I couldn't help but think when I saw that the amount of money which the scheme used as relief to members of the saying which says no good deed goes unpunished, because of course if the reserve was used in such a big way to help members, that reserve now needs to be built up again. So It's a give and take situation. And I wonder in retrospect, and maybe this is actually the only question I will pose before I give over to members, is if the scheme thinks that that was the wisest decision, because now you sit with the pain of people of members who don't understand why contributions are going up above what they are used to the previous few years. But nonetheless, thank you for the presentation. It does seem at least as if the fund is well managed and in a good financial position. But of course, the interest of public servants, and the fact that things are all around, not just medical aid, all around things are expensive, and people are very sensitive. Public servants are very sensitive to price increases of any sort. With that much being said, members, we now go to the next part of the agenda where we will do the deliberations. I would just like to ask members, as a courtesy, I usually do ask this, if you can just temporarily switch on your camera when you start speaking, and you are most welcome to turn your camera off. Then after you've done that, if you're not in a position to do it, maybe just mention that when you start speaking. As always, I'm going to try and ask members to keep their remarks and their questions to 4 minutes. After 4 minutes, I will ask you to conclude, and I will give you a grace of an extra minute, so that you in total have 5 minutes to make your remarks. That usually gives us about an hour of remarks to do, which I think is sufficient. And then lastly, I just think that I would appreciate it if members stay as professional as we are used to in this committee. Our members usually conduct themselves very professionally. I would like members to ask the hard questions, ask the difficult questions, but as far as possible, let's play the ball. Let's not play the player, and let's keep it professional as far as we can. I would really appreciate that. And then I'm going to start asking for hands. I see Honorable Kaba has already put up her hands, and I will go according to the
Sorry, Chair.
hands.
Sorry, Chair. Sorry for
Honorable,
interference.
Honorable
Chair,
Wane.
Chair, I'm traveling. With your permission, can I follow Ms. Kaba because I'm traveling? I'll be in
Yeah.
a transport.
Yeah, that's not a problem. At the moment, we only have Honorable Kaba, Honorable Langa, and Honorable Pulwane's hands. So, yes, Honorable Pulwane, I'll make sure you get an opportunity, and I note the fact that you can't put up your hand online. That's not a problem. So let's start with Honorable Kaba, and then we will move down as I see hands on the platform. Honorable Kaba, you are welcome to go ahead and ask your questions. Thank you.
Thank you very much, Honorable Chairperson. Good morning to you, Chair, and good morning to all members in the platform, and good morning to the department, James, Honorable Deputy Minister, our guest, Honorable Chairperson of Health, Honorable Mtambi. Chairperson, before wasting time, let me start to shoot straight to the question of the board. Let me welcome the presentation of the board of trustees of GEMS. Honorable Chairperson, the board responds to matters currently under investigating concerning trustees who are public servants, including what interim government measures the board has implemented pending on outcome of those investigations. My question is that, Chair, are those members still currently serving as active board members in the scheme or not? If yes, why? Chairperson, I don't want to embarrass anyone in this meeting. I won't call anyone's name because James know very well about their members. There are some members in James who are working in Department of Health. Example, in Mpumalanga, who are getting paid by the department. They are also getting paid by the trust. Now, the second one is working in Gauteng, Department of Health. I won't call names. They know each other there, as they are preventing the corruption. Chair, those members, they are paid by the board also, which means they are paying double. I will ask the board, please provide portfolio committee with a full leave record. Take calendars as per PASA logic, audit and GEMS meeting calendar, attendance, register attended in the past 5 years. That one. Chairperson, the board approach where allegations arise concerning potential conflict of interest involving commercial relationship with entities conducting business with GEMS. In this regard, Chair, the committee requested the board to explain its conflict management framework and how it applies that framework in individual cases where potential conflicts are identified. The board to provide declaration forms of all members made when they join GEMS board and all declaration register where some of service where some of service where some of service providers or its related companies were party of the agenda. Chairperson, the agenda of today, James talks about oversight, conducting oversight quarterly, but previous board handed over matters in the SIU of malfeasance and corruption and corruption. Now, how far are their investigations in all these issues? And what was the outcomes? If they are seriously conducting oversight quarterly, they must provide us with the answers of outcomes of that investigation. Who was handed over by the previous board about the issues arises and handed over to the SIU. Again, Chair, the board talks about the strategies for detecting and preventing fraud and waste to reduce medical aid scheme expenditure. Chairperson, this is ridiculous, serious. I must tell you. Because the same VEL board, they have some board trustees who are paid double. Did they don't detect that fraud? Because those trustees are still working government and they are board trustees in other side in the GEMS, but they are getting paid both side. That is not a fraud and corruption and wasteful expenditure.
Please conclude.
As I conclude, Chairperson, my answer, the answer of this question is no. These trustees actually, they are escalating the expenditure to the board. So, as I conclude, Chairperson, I think this board must understand that they are dealing with a middle class, poor middle class chair. The money that they are paid themselves is more. And this middle class, they end up when they are hospitalized, having a problem of the money being finished before they discharge in the hospitals. Now, why are they paying themselves more than to keep the money for the people who are contributing? They are contributors. If you can see, Chairperson, the list is endless. If I have time, I will read. Maybe some members, they'll read it. The money that has been used by this board. Yes, I agree with them if they are talking about Discover and Bonitas, but it will be better because that money, it can serve the purpose. When the middle class are hospitalized, the money won't be finished before they discharge in the hospital. I thank you, Chair.
Thank you very much, Honorable Kaba. So questions of potential double dipping or getting paid double and corruption matters are handed over to the SIU. Honorable Pulwani, I'll give you an opportunity now and then I will follow the list after that. Honorable Pulwani, please proceed.
I try to open, yes. Can you see me? I will switch off my camera, Chair. Thanks.
Thank you,
Chair,
Honorable Pulwani. Please proceed.
yes, Chair. Let me not waste your time, but thanks for the opportunity and good morning to you, honorable members, our DM officials, the GEM representative, and also the chairperson of the health, Ms. Mutambi, everyone in the platform. Chair, let me join my colleague by welcoming this detailed presentation from GEMS. And thanks, GEM, for giving us this information. But I just want to check something, Chair. Recording in progress. According to the presentation, the performance for 2026 they say is stable and is recovering. But my question is, what root cause preventing the scheme to achieve 4 of the 7 DPSA aligned KPI in Q2 2026? And what operational corrective measures are being deployed to raise the overall percentage, 58% APP target achieved rate before end of this year, this 2026? The next one, given the significant cost of growth in specific in hospital categories such as blood transfusion and other services, what clinical management control or tariff negotiation are being implemented to cure the high growth expenditure drives? The next one, Chair, is how does the scheme risk profit different across the provinces? And then the next one is the scheme accumulates reserved at the expense of members currently benefit, and how does the board balance present and the future member needs? The last one, what is being done to increase the appropriate use of primary health care? Thank you, Chair.
Thank you very much, Honorable Pulwane. Honorable Langa, you are next. Please proceed.
Before I proceed, Chair, can I apologize and request to keep my video off? It's election season, so where I'm at, the bandwidth is not too good.
Understood. No problem, Honorable Langa. Please proceed without your video.
Okay, thank you very much, Chair, and greetings to you. Greetings to DM Mamkekana. Greetings to GEMS representatives, honorable members, and the support staff across. Let me also join my colleagues, Chair, in welcoming and appreciating GEMS' very comprehensive presentation. I have just a few questions. Some, I think they come across as just clarity-seeking questions. Some, maybe they need a detailed response. The first question will be, if GEMS does have a detailed analysis available for the 4 KPIs that were not achieved at the end of Q2. The second question will be, maybe to give us an explanation as what accounts for the differing reserve ratios between 2025 and 2026. Maybe if I can repeat, what accounts for the differing reserve ratios between 2025 and 2026? The third one will be, what oversight mechanisms are planned or are currently in place for the advanced AI detection tools that aim to target fraud, waste, and abuse? Number 4, a provider member coalition. It threatens both financial and ethical integrity of the scheme. So the question will be, what procedures are currently in place to prevent collusion, and what channels have been established to allow for such instances to be anonymously reported? And the last one will be, given the proposed, now declined, reduction of GEMS member contribution to 7.5%, are there currently any ongoing discussions regarding additional charges to the contribution rate? I think, Chair, I will pause there for now before I go to 7 minutes like the whip. Thank you, Chair.
Good morning, Chair. Can you please note me?
Is it Honorable Tikana?
Yes, Chair.
Okay. Honorable Tikana, I will give you an opportunity after Honorable Mutambi. Then you will have your opportunity.
Thanks, Chair.
Honorable, it looks like Honorable Letlape. Am I correct? Nkosi's iPhone, is that Honorable Letlape?
Yes, Chair, you are correct.
Fantastic. Honorable member, please proceed.
Okay. Mine will just be 3 quick ones. Is there any intent from GEMS side to separate fraud and waste, fraud from waste and abuse, so that when there's fraud, the scheme should not be aiding and abetting? Fraud should lead to criminal prosecutions and time, in addition to cost recovery. And the two need to be separated. We can't be putting them in the same sentence. The second question is about affordability going forward. What are the actuarial projections of appropriate increases going forward to be able to keep the scheme sustainable with appropriate reserves? And what percentage of premiums are being put to restoration of the reserves? Because as you increase your subscriptions, you increase the reserve requirement as a percentage. In terms of your benefit structures, do you have any plan of increasing the expenditure to primary healthcare and primary physicians so that we can have promotion and prevention being part of what is funded by the scheme? And we can see the cost of hospital care going down. I mean, funds complain about the cost of hospitals, but their benefit structures are hospicentric. And members get to understand, for sometimes to get a benefit, you got to get into a hospital. If you're outside a hospital, there are no benefits there, and you got to pay out of pocket. So for me, it's just about those issues in terms of how are they being managed going forward. And lastly, when you look at your 5% expenditure, as you clearly illustrated, most of it goes to managed care. Would there be a point at which the administrator would be fit for business so that that part is not part of what you pay out? It's part of your competencies that are built into you as a scheme so that you can lower the percentage that goes to non-healthcare costs. Thank you, Chair.
Thank you very much, Honourable Member. Honourable Mtolo, you have the floor. Please proceed. Honourable Mtolo, you next. You can proceed. I see, Honourable Mtolo, you are unmuted, but we seem to not be hearing you. I'll give you just a few more seconds to see if you can sort it out. Honourable Mtolo, unfortunately, we cannot hear you.
You know,
There you go. There you go. Welcome.
thank you.
Please
Chairperson,
proceed.
please allow me to speak without opening my video. I'm experiencing difficulties with the video.
No problem, member. Please proceed.
Thank you, Chairperson. Greeting to the honorable members and all officials and department present. Firstly, I want to welcome the reports that's been presented to the committee. Chairperson, I have a few questions with James. Number one, what alternative solution James offering members who cannot afford the 9.5 increment? Are you engaging with the government and organized labor on any other form of relief? Another one, non-healthcare expenditure. You indicate that non-healthcare expenditure is around 5%, and that this is one of the lowest in industry. Can you provide the committee with a clear breakdown of this 5%? In particular, how much goes toward administration, staff cost, outsources services, and head office expenditure? On claims management share, the terms indicate that management is being strengthening to control unnecessary utilization and wastage. How do you make sure that claims management does not become a barrier to members accessing necessary health care? Where do you draw the line between controlling cost and restricting access? I thank you, Chairperson.
Thank you very much, Honourable Member. Honourable Pelise, you have the floor.
Thank you very much, Chairperson. Good morning to you. Good morning to the DM and everyone in this meeting, Chairperson. Chair, I think, Chair, I just need to raise an issue with you first. I think in your introductory message, before you handed over for deliberations, you do give an impression that you want to guide us in terms of like how we should go in this meeting, and give an impression that, we don't carry ourselves in a manner that is acceptable as members of this committee. And I think I would appreciate it that if you can just hand over without, insinuating other things, and allow us as members to engage whatever comes before us without you trying to guide and give a direction to whatever needs to happen in terms of, the meeting and the presentations and things like that. I just need that respect from your end, Chairperson, to allow members to conduct themselves in a manner that they know. We know what is parliamentary, we know what is expected of us and what is not. I just wanted to get that out of the way, Chair. Now getting into the report, Chairperson, there is never a time that James comes to appear in front of this committee and they just don't expose how corrupt they are. They are fraud and they are corrupt, and they continue to not live up to the objectives to which they were established. GEMS was established so that they can, lift a burden off the shoulders of poor people. But every time they come here, they expose themselves, how much they continue to take from those very people into their pockets. And then I wonder if they know why they exist in the first place, because I think no matter how much we engage them, and I asked them this question previously when they came to appear in front of this committee, but do they know why they exist? And they continue to prove that they don't. Chairperson, where we saw the news yesterday that their PO has been suspended, and the chair of the board doesn't give us details here. They must give us details. Why is their PO suspended? We deserve to know as members of this committee, because we know or we hear that they suspended the PO because he allowed a person to go home with a laptop. If they are so quick to suspend a person for going home with a laptop, how are they not quick to suspend people when we've been raising alarms to say there are people who are double dipping in their board? Why are they not quick to suspend those people who are stealing money of our people? They suspended people. They must clarify to us, why is the PO not in this meeting? Why is the PO suspended? Is it because he allowed someone to take a laptop home? And if they are so quick, they show themselves to be so quick to be able and to even have an ability to suspend people, why do they still have people who are double dipping in their board? You see, GEMS continues to focus on fraud and waste and abuse by members and healthcare providers, while they are failing to adequately account for its own non-healthcare expenditure and governance. They are quick on many other things, but those things. Chair, GEMS must explain why substantial amounts of money continue to be paid to Medscheme and Metropolitan Health. We asked this question when they came to appear in this committee before. They must explain to us, why do they continue to pay these substantial amounts of money to this Medscheme and Metropolitan Health for administration and other services, and why these costs have increased over the past 6 years? Because we see they've increased GEMS cannot simply report that its non-healthcare cost ratio has improved. As this committee and parliament, I think when they know that, they should know that when they come to this committee, when they come to parliament, we need the actual rents amount, year-on-year increases, and the contractual escalations. We need evidence of value for money. They can't just want to tell us, and then we must take their word for it. We know that their payment to Med scheme increased from 400 million to almost 1 billion in 2025. How does a payment increase that much from 400 million in 2020 to almost 1 billion in 2025? That it's an increase that is approximately 500 million.
Please
I
conclude.
don't know how much percentage it is. I'm going to need you to give me more time, Chair, because we've asked for this meeting, and I'm very disappointed that the minister is not here, because we've been asking for GEMS to come and the minister so that we can deal with these issues. So I need you to allow me time to deal with these issues, because even when we write to them, because last time we agreed.
I'm
Chair,
going to
I'm need you to. I'm on the floor, Chair. Please listen to me.
I'm the chairperson and I'm on the floor. I'm going to allow you to ask your questions, but all I'm asking you respectfully is to not talk too much about other stuff. Just ask your questions.
No, you can't. You can't tell me what to not talk about, Chairperson. And that's what I'm saying.
I have to be fair to everybody. I give
no.
everybody
You
the same
can't.
time.
You can't ask me what to talk about in this meeting when I'm talking to GEMS.
I'm
And
not
that's what I'm
directing you.
saying. You treat us as your children. We are not your children in this meeting. I am going to raise
I'm on the
issues
floor.
that I need to be
I am on the
raised.
floor.
Chair.
I'm going to. If you're not going to respect me, I'll have you removed from the platform.
Oh, you are not.
Please
Why would you
respect
want
me.
to remove me? How
Please
did I not
respect
respect
me.
you?
Because you are talking while I am on the floor. I'm asking you respectfully to just be to the point in your remarks, to respect the other members' time. That's all I'm asking you. Please proceed.
Okay, I'm about to finish, Chair. Just allow me to finish.
Thank you.
So I am saying, you see now I lost my train of thought. Chair, we have raised this before, right? That there is a serious government concern regarding trustees who are also public servants receiving money from GEMS for GEMS board duties. I wrote a letter to the minister, and the minister responded to me that Ms. Constance Nchane and Precious Khumalo are employees of Provincial Health Department, and that the relevant authorities were requested to establish whether they had permission to perform, these remunerative outside work duties, whether they took leave for GEMS or things like that. We need that is the letter the minister wrote a couple of months ago. So we need clarity on that. What is the status of Constance Nchane and Precious Khumalo? Because the minister was saying that we need clarity on whether they took leave, what was established there. The minister further cites that Section 31 of the Public Service Act, which provide consequences where remuneration is received, contrary to Section 30. Against this background, Chairperson, the reported remuneration is highly concerning of Ms. Nchane, because it's approximately 8 million over the period of 2020 to 2025, and Ms. Khumalo approximately 5 million. It's over 5 million, almost 6 million over the period of 2021 to 2025. GEMS must explain what action its board has taken regarding these governance concerns and the outcome of the minister's investigation. We need to know that, because we can't write to ministers and board and raise these issues, and then there's no clarity or responses to us. The fundamental question is that GEMS must tell this committee that it is committed to affordable healthcare for public servants. They don't do that. And we see that in their projections, that is not what they're doing. And we want the status, because they did talk about insourcing, GEMS presented an insourcing strategy here to Parliament with an objective of bringing these administration capabilities in-house. Its current presentation still identifies insourcing of capabilities as a strategic objective. Where is the implementation report? They need to tell us, because we don't see. Where is the implementation report? Because the current approved one states the deadline of 2026, and we are in 2026, Chairperson. So as I conclude, Chair, we need a 6-year forensic breakdown. And I'm going to write this to GEMS like I did the last time, that we need a 6-year forensic breakdown of payments to Medischeme and Metropolitan Health. We need a complete metropolitan procurement and a contract file since the first contract with GEMS. We requested these things, and this was last year, we still have not received them. We need a list of all triple BEE or 30% SME as per GEMS rules and Parliament requirements. And we need the 2021 Insourcing Board Resolution business case. We need a current status, and we need the milestones and the full analysis of GEMS internal staff versus the outsourced functions. Because then if they're saying there is a problem with insourcing, they must tell us how much it is costing them to outsource instead of insourcing. And we need the minister to table the outcome of the investigation referred to my letter, Chairperson. Thank you very much, Chair.
Thank you, Member. Honourable Mutambi, you have the floor. Please proceed. Or I should rather say Chairperson Mutambi. Welcome again. Please proceed.
Whatever, Chairperson. Thanks for the opportunity. You'll also pardon me, I'm not in the right space, Chair. But I felt there are issues that one need to raise. Also, I must say upfront, we are engaging with the Council for Medical Schemes because one of the key mandates of the Council for Medical Scheme is to protect the members' interests. So there will be a meeting that you will also be invited with your committee, wherein we're going to meet with GEMS to also look at some of the issues in line with the role and the mandate of the Council for Medical Schemes, which administratively falls under our oversight. However, Chair, I just want to ask a question that relates to governance, administrations, and scheme performance. I want to put this, Chair, which is commonly known that GEMS is a restricted medical scheme established specifically to provide accessible and affordable healthcare coverage to the South African public servants. So I just want to get it from the board. Does GEMS consider itself to be successfully delivering on its core principles of accessibility and affordability? Also, given the status as a government-backed entity, why is GEMS salary structures not aligned with the public service pay scales? And why does the scheme not operate out of state-owned properties to reduce costs? Also, considering the high frequency of GEMS board meetings, as one read their integrated reports, why has this not translated into improved or more cost-effective benefit options for members? And what specific strategic matters are being addressed during these sessions? And then the other issue that relates to that, what distinct value does GEMS add as an intermediate entity, given this, that the state could contract directly with Momentum to deliver healthcare administration services to public servants, thereby eliminating redundant overhead and passing the cost saving directly to members? There's an issue that is very worrying, Chair, that relates to the affordability of low-income earners. I want to understand how is GEMS addressing the financial strain on entry level, in particular levels 1 to 5 public servants for whom monthly medical scheme contribution consume a disproportionate percentage of their basic salary. I'm talking to the increase of the Tanzanite one. And then how does GEMS justify percentage increase when its primary mandate is to provide affordable health care to government employees, particularly lower income earners? And given the substantial accumulated reserves held by GEMS, what specific actual strategy or relief mechanism are being deployed to lower member contribution or expand primary health care benefits without threatening the scheme's long-term solvency? There's an issue that we have read over the past that the board has previously announced its intention to insource certain services to reduce administrative costs and improve value for GEMS members. Why has the progress in implementing the decision been so slow? What specific governance, operational, or contractual obstacles that are causing the delays? And by what date will the insourcing process be completed and the anticipated saving passed on to the members of the scheme? Chair, as I conclude, I want to also get clarity as to how does the scheme justify high income for scheme executive management? Why are GEMS employees not on the same salary scales as public servants, as the scheme is for the public service? And what structured feedback loops exist between GEMS executive management and the organized labor structures via the platform like the Public Service Bargaining Councils to address recurring member grievances regarding denied authorization, chronic medication management, and benefit structures? So these are some of the issues that I felt we need to seek clarity on. Like, as I said, one is of the view that we're gonna have a meeting on our side wherein we'll have to call every stakeholder that is involved, in particular the Council for Medical Scheme, to explain to us how is it protecting these low-income members who are members of GEMS. Thank you, Chair, for the opportunity.
No, it's a pleasure, Honourable Chairperson Mutambi. It's nice to have you with us, and thank you that you were to the point. Lots of important questions, and I appreciate that you made the time to be with us today. Honourable Malinga, you have the floor. Please proceed.
Thank you, Chair. Let me greet you, DM, and all protocol observed. Chair, mine will be few minutes because it's an advantage to speak at the last where everybody have chow everything on the table. But Chair, there are lots of contradictions here with GEMS. Firstly, if you check the fundamental or the objectives of GEMS, the first one is affordable healthcare. The second one is to improve access to healthcare. The third one is to promote equitable benefits. The fourth one is to support. Fifth one is to reduce pressure on public healthcare. You can name them. But what we see and realize is that as soon as they are giving us presentation, so that is where we are losing the confidence to them. I think, Chair, we need to declare this to GEMS board that it seems like currently the public servants are not helping the public servants at all. We cannot shy away, Chair, from the issue of the the suspension that took place currently of their principal officer. Although there is an interim measures pending within GEMS, but we believe that as the portfolio committee, it's a must for us to have the full information of what's transpired to their PO. I think that is very important for us as the public servants. Two, Chair, based on the elaboration that other members have already take care of it, let me check that it seems like the risk profile is not similar from all provinces. So I just want to check that how does the scheme risk profile differ across provinces? In closing, Chair, I think for me, where I stand, it seems like GEMS it's working like a scam that is scamming the public servants. I don't want to be seen as a broken record, but as soon as they are coming with presentations, it's just exposing GEMS how they are failing the public servants. Lastly, Chair, I just want to check that what is GEMS currently assessment of its financial sustainability over the short, medium, and long-term plan. The last one, Chair, is what is the project impact of chronic disease, disability, and high-cost treatment on the scheme future liabilities? Chair, because I'm respecting your time, I don't want to go on and on and on. I think some of the issues that I'm not happy with, let me consolidate it and send it to James directly through email. But it's a humble request and plea, Chair, that from last year, we have requested number of things. Till today, James have not yet finished us with that information. So we are appealing to James to take this committee seriously. Any information that we are requesting to them, let them finish us with that information as soon as they can. Thank you, Chair.
Thank you very much, Honourable Malinga. Members, that closes the round of deliberations. Although I see the Deputy Minister's hand is up, I think, yes.
Hey, you noted me, but I'm in transit, but I'm interested in contributing or in asking some questions.
My big apologies, Honourable Tikana. Yes, I did note you, and it is your opportunity. And after that, the Deputy Minister. Honourable Tikana, please proceed.
Thanks, Chair. As I'm in a... Let me greet everyone in the meeting. For now, I'm in a transport. I would wish if it was possible to request the Chairperson of Health for me to share my questions with her, as I believe she is in a stable area to ask, because I believe others are traveling. But Chair, let me ask few. Let me say, Chair, first of all, I will request in a meeting which the health chairperson is inviting us, that it be a physical meeting. If we missed some questions, we make submissions of those for you to share those questions with her, for them to be responded to in the meeting, which will be shared. Chair, I would like to know what specific statutory calculations did the Council of Medical Schemes cite when rejecting the proposed 7.5 contribution reduction for July 2025, and how will GEMS ensure its statutory reserve ratio reaches the target of 25% by 2030 without imposing step future contributions hike on members? Also, Chair, I understand James want to insource, and when insourcing, I believe there must be accommodation and other matters. In my view, what delays the insourcing process in the processes? If to me it's an issue of accommodation, can't James look for a building, not to build a new building, to look for a building to accommodate the staff which needs to be insourced, because insourcing, in my view, is not happening, it's being delayed. But if it's an issue of a property, I would recommend that they look for accommodation and, if possible, sell the existing land, which I believe that it can be cheaper than any other issues. Sell the land and buy an occupied building around Pretoria to accommodate the Then there are issues on accommodation and on governance and cost drivers and accountability. Chair, the public sector unions governance consent have become more significant in light of 2026 affordability dispute. Before members are required to absorb further increases, there must be full transparency regarding the scheme's major cost drivers and the measures taken to certain them. Chair, I would like James to appraise us on the following: a detailed breakdown of administration and non-healthcare expenditure, including outsourcing and service provider costs. Secondly, Chair, disclosure of the principal drivers of claims, inflation, utilization increases, fraud, waste, and abuse. Thirdly, Chair, if we can be presented with the rationale for material board and governance expenditure and the value derived from such expenditure. Chair, a review of the cost and performance of outsourced administrators and other major service providers, and an independent review of forensic audit where governance, procurement, leakages, or value for money consent, Chair. Then lastly, Chair, if James can present to us a clear accountability measures for executives and trustees where preventable failures materially prejudice members. Those are the issues, Chair, which I wanted to raise. I still have some, but as I told you, I'm inconvenienced because I'm in transit. Thanks, Chair.
Thank you very much, Honourable Tkana. Deputy Minister Kekana, you are welcome to take the floor.
Chair, I hope it's a response time, unless if you want to comment before I come in.
No, indeed, Honourable Deputy Minister, it's response time and you will lead the response, whereafter I will give the GEMS delegation the opportunity to respond.
I really want to thank the fact that as the chairperson, you also allowed the chairperson of health portfolio to be part of this meeting. And we should not undermine the fact that the chair of the portfolio is the former Minister of Public Service and Administration. So she also has a historical footprint of some of the journey that James has walked. I fully agree with the chairperson of the Portfolio Committee of Health, and even appreciate the fact that you allowed her to be here. But I further want to make a suggestion that in the next 14 days, if it's possible, I know we're going on recess, maybe immediately after recess, health portfolio, DPSA portfolio, and Standing Committee on Finance, we must come together as one and have a full session as the DPSA with the 3 committees. And what I will do, I will request Chairperson Joe Maswangani to also bring GTEC, because GTEC is an entity that looks at porosity of government and potential failures that come in government entities. It is an entity that bail out entities of government when they fail out. Already they are working on certain things on GEMS and they are not happy. And I think that meeting of the 3 of us, but that meeting, as Honorable Mutambi is saying, it must include counsel for medical scheme, so that we look at the totality of things and then look at what we said, what was the objective of establishing GEMS: accessibility, affordability, including the resolution that was taken in 2021 when GEMS said to Parliament, by 2026, many of the things will be done in-house. So those reports are there, and we must even be able to say, how far have we gone in ensuring that we in-source going forward? Because members are concerned about cost reduction. Members are concerned about distinct value that GEMS is supposed to do. Why do they still depend on a middleman? Middleman will be momentum and everybody. Members are concerned about cost reduction and all those things. So it needs the 3 portfolios to look at these things and scrutinize. And then how do we look at the financial strain for low-level entry points? So we must look at those things and then be able to deal with that. I think the request I'm going to make is for the chairperson, yourself, the chair of health, and the chair of SCOF to meet with minister. Prepare for this meeting that we want to see taking place. Public servants are going through a financial strain. How do we, all of us, look at totality of issues and then say, going forward, what are the building blocks to deal with this? That's my suggestion, Honorable Chair. The second issue is the issue of conflict of interest of board members. I'm proposing, and this thing has been coming and going. I want the committee to give me 7 days. I'll talk to the minister. It's not my delegation. I'm going to meet the minister today. I'm going to physically go to the MEC in Mpumalanga and the MEC in Gauteng, and then ask them in writing what they have allowed the members to do. How do these members then mitigate on their absence as they are in the board? How do they fulfill their primary responsibility because they are employees of government, including what the committee is asking for the past 5 years? How much have these people been earning, and how were they, did they get permission and all these things, so that we put this thing to rest. Give me 7 days. I'm going to tell the minister today, we have parliament. I'll take it upon myself, drive to Mpumalanga, go to Gauteng, have one-on-one with MECs, let them clarify their stance. Once that is done, commit in writing, bring it back, because it has been going forward and backward. The appeal I'm going to make to Dr. Tutu as the chairperson of the board, let's stop saying 5% of 100 Rand as non-healthcare costs. What are we saying in rented sense? How much of non-healthcare cost are we paying? From the 5%, what comes to GEMS and what goes to administrators? Let's say that. Why are we not transparent to Parliament to show Parliament? There's something that we have picked up. We are also doing our work in the background, Chair. Public servants are excluded in COIDA. The injury on duty for public servants is not paid elsewhere, and GEMS is carrying that burden. But what does Discovery do? If a public servant who's on Discovery, or if anyone who's on Discovery and works for government or whatever entity, Discovery is able to go back to government and claim the money for whatever that happens. Is GEMS doing that? Because some of the employees may be having all those things, and we don't have a mechanism to claim from government. And this is why the costs of GEMS go escalating. And that's why GTech, National Treasury, is looking at that and saying, how do we bring in something that can mitigate on this thing so that not all the burden is given to GEMS? I'm speaking under correction. I don't want to be seen, to be heard, to be misleading the portfolio committee. I'm picking up a sense, and this is still in the grapevine, but I want a meeting with the president of Pop Crew. It looks like correctional service employees want to move out of GEMS. I don't know how true that is. I'm still going to investigate. I have a meeting with the president, and it then says, they're saying we're moving out of GEMS. We can rather go to PolMed because GEMS is becoming expensive. This is not factual, Chair. Please don't hold me accountable for now. I'll come back and report and give you feedback. What Dr. Tutu and her team must do is this evergreen contracts, metropolitan or whatever. How long have these administrators having these evergreen contracts? How are we going to mitigate on this thing? How ready are we to insource some of these things? So whatever I'm saying, I know I'm putting the spanner in the wheel, but these are the things that trade unions are inundating us with every day. So I'm saying, portfolio committee, give me a chance. I'll give the minister this report, but I'll also say James committed that by 2026, they will be insourcing many of the things. How far are we? How ready are we? And all these things, and then be able to deal with that thing. But the plea I want to do with you, Chair, that meeting of the three committees, Health, Standing Committee on Finance, and Public Service and Administration, to sit together and say, how do we deal with the plight of public servants? We can't have the biggest medical scheme in the country, but it becomes so unaffordable to our people. And we talk of 5%. 5% of what? How much is that 5%? Where is the 95% going? And how much is that 95% in rands and cents? Why should we always be given percentages and so on? And I agree with members. Let's go, Dr. Tutu, and bundle all these things, bring information. I'll tell the minister because it is his portfolio, and I'll say, these are the commitments I made to the portfolio committee. Thank you, Chair.
Thank you very much, Deputy Minister. Members, I see Honorable Trilise and Honorable Malinga's hands are up. I will give members a second bite at the cherry after GEMS have given their replies. But I just want to check, Honorable Trilise, Honorable Malinga, do you have points of procedure or points of order, or can the presentation go on, the replies go on, and then I will give you an opportunity at the end?
Chair, I don't know, because I wanted to bring attention to a point that the DM has raised in terms of like the meeting between yourself and the chair of the health committee.
Okay. No, that's fine, member. I will commit to giving you an opportunity to bring that up at the end when we've heard Jem's reply. I don't have a problem with that, but I'm just going to ask Jems to quickly or to do their replies, and then I will give you the first opportunity after that to voice your concern. Thank you. Jems, if you can just proceed with the replies. Thank you.
Thank you, Chairperson. May I take this opportunity to appreciate the engagements with the portfolio committee members, with the Deputy Minister, and all the members that are present during this time. I'm going to allow the responses now. Can I just take first our legal counsel to respond on the matters pertaining to legal position of trustees, and then follow with Dr. Vuyo, because they will be flying out to Cape Town shortly. We've got a symposium, GEMS symposium, that is happening, and then I will then follow up with the rest of the other execs to respond specifically on the questions that have been highlighted by the members. Thank you. Can I ask legal counsel to please respond?
Chair, thank you very much through you, and please excuse my camera not being on. I'm on the way to the airport to travel for GEMS matters. Chair, just with regard to the appointment of trustees, in terms of the provisions of the Medical Schemes Act, a minimum of 6 of our trustees must be elected by members from amongst members. So it's inevitable that half of our board will be public servants because of that provision of the Medical Schemes Act. These trustees are elected through a fair and open process by the members of GEMS, so by fellow public servants who belong to GEMS, Chair. We run an independent process. We appoint independent third party to oversee that process. And other than GEMS's obligation to make sure that the elected persons meet the fit and proper criteria in terms of the Council for Medical Schemes' guidance for what should be measured on that. James does not have any influence or control as to who is elected. Once the election results are announced and the appropriate fit and proper assessment is done, James cannot then control who is appointed. Then with respect to RWOPs, Chair, we have the necessary approvals, or we've received copies of the necessary approvals that were issued to the elected members. And then James obtained legal advice on the matter as well subsequent to the query being raised. And the legal advice given to James is that if James is satisfied that, or if James has been provided with a copy of the RWOP's approval, that is James's obligation and the end of its ability to investigate the matter. The other matters, whether leave was taken or the like, that's part of the employment relationship between the department and that specific employee. And James has got no right to interfere in that. And it's also got no right to request copies of leave approvals or any similar matter. That's a matter that must be dealt with between the employer and the employee. Thank you, Chair.
Thank you, Manus. Dr. V, can you please respond to the issues pertaining to you?
Thank you, Chair. I will respond to the issues, the questions that have been posed with regards to claims management, primary health care, hospice-centric care, as well as insourcing of capabilities. But I do want to note the comments that have been made by the Deputy Minister that there will be a detailed report that will be provided with regards to insourcing and where we are and what the plans are. Chair, so I will start with the questions that pertain to what are we doing to promote primary health care and channel members to primary physicians. It also spoke about the problems of hospice-centric care as well as claims management. So I'm going to holistically approach that question, those questions in my answer. GEMS has a strategy to encourage members to to nominate a GP and actually use their GPs, nurse practitioners, as well as pharmacies, which are primary healthcare practitioners, as their first point of entry. We encourage that members should not go to specialists, rather start with a GP, who is the first point of care, as is the plan in any primary healthcare, structured healthcare environment. This then helps in terms of managing the costs, also managing the members and patients with regards to avoiding unnecessary hospital admissions as well as unnecessary specialist referrals. We're not saying that specialists mustn't see our members. We are saying that the GP should be the coordinator of care. GEMS also encourages members to go for screening tests on an annual basis. And I'm just going to make an example, Chair, a few examples in the interest of time. Get their blood pressure, their blood glucose, their pap smears, and a whole lot of other screening and preventative tests. They must have these. We encourage them. We spend a lot of communication with members, advising them the importance of screening tests. And this prevents diseases down the line, but also it helps us to and the doctors to actually diagnose early on, which then does reduce the costs. And how we promote this and encourage members is that this is paid from what we call the risk benefit, which means it's not going to affect the day-to-day benefits that the members have. So they can still use their day-to-day benefits, but all the preventative and primary healthcare screening services are paid from risk, and they can do it at least twice a year. It is a member's option. Some members prefer to go to nurses, other members prefer to go to primary care physicians or to GPs. So there is an intense strategy and education approach to educate members about the benefits of primary health care as well as preventative care. The environment that we will operate in the private medical scheme space, chair, is hospice-centric, meaning that the care is primarily driven in the hospitals, and doctors tend to admit a lot more. So you can see how the efforts of trying to channel members towards primary health care is meant to actually prevent the hospice-centric care approach. There's also various things that are done in the industry where GEMS is partnering with other entities in the industry to make sure that there's what we call a holistic approach, which is multidisciplinary care, where all doctors or professionals are working together holistically in looking after the patients from a value-based approach. And this is all meant to try and drive care from hospice-centric to primary healthcare based. I do have to say, Chair, that this is an endeavor that the industry in the private sector has to do together, both funders as well as private healthcare practitioners. I do believe that there is a slow move, but I do know that there's a lot of dedication in terms of changing the way that we practice healthcare in the private healthcare sector. With regards to claims management and how we are managing the claims blowout on a number of matters that have been pointed out, there was a reference to blood services. There's a lot of over servicing in the hospital. In the claims management space, Chair, there are, and this is where also the role of what we call a managed care organization comes in. There are treatment protocols and guidelines that are used in authorizing procedures. And these are put in place to make sure that while we manage the overutilization or the wastage that is there, and perhaps an example of a wastage is someone who has blood counts or a full blood count done every day or twice a day, 2 or 3 times a week, which is unnecessary because all a physician needs to do is check the blood results that were done. There are certain tests that don't need to be repeated within certain minimal intervals. And we encourage this, and we try and work with the relevant practitioners, pathology groups. We also actually engage with the doctors that are outliers where there's overutilization. We do this, Chair, to make sure that we don't restrict access. We just manage the wastage, but to make sure that we don't restrict access. Anytime where there are rules put in place, there's always exception management to make sure that if a member is an exception and there are complicated cases, those cases are able to be managed on an exception basis to make sure that we still provide access that the care that we need, that the member needs. Then with regards to the insourcing of capability strategy, Chair, this is a progressive strategy that is being implemented over time carefully, and it is a risk-led approach that we have taken. GEMS has an insourcing of capabilities strategy. We started implementing it quite a few years ago. There is a lot of progress that has been made, Chair, in terms of insourcing. There are areas of administration and managed care that have been identified. A lot of those have been insourced, but not all functions from a managed care and administrator point of view have been insourced. But there are also other services that have been insourced over time, for example, cleaning services, security. From a managed care perspective and admin perspective, the oversight and management of networks, of all the healthcare networks, is actually done at GEMS. While some of the administrator functions like call center, registration of membership are still done by the administrator, which is Metropolitan, which is a current administrator, as well as other functions like chronic disease management, treatment protocols and guidelines, and pre-authorization for hospital procedures are still done by managed care. We are incrementally looking at where does the expertise lie, and we are I'm gonna again say we use a risk-led approach in terms of slowly incorporating and insourcing some of these services, Chair. And I hope it does answer to the fact that what do we pay, what is it that we pay our subcontracted services for? We pay them for the services that we have not fully insourced, Chair. The reason why the costs are going up is because we are bound by the contracts to increase the fees by CPI every year, but also, Chair, GEMS has been growing significantly over the past few years. So we have to pay the people that are contracted to us based on the members that they service. So there are certain fees that are paid per member per month. So the more GEMS members there are, and we're talking principal members, the more that we have to pay for the service that are rendered for them. Chair, I would like to also add that from a BBBE perspective, every contracted entity at GEMS is bound contractually to meet certain BBBE obligations with regards to the services that they provide. They need to make sure that they subcontract and they bring smaller industry players and to try and break down the monopoly that exists in the private healthcare space, as was reported in the HMI report and recommendations. There is also a supplier development program that is dedicated at head office at GEMS, where we, in addition to the contractual obligation in terms of promoting BEE, there are various entities that are supported by GEMS to make sure that they're able to enter the industry and they get the support that they need. Chair, I'm going to stop there and hand over to my other colleagues to answer the rest of the questions. I'll try and join while I'm driving to the airport, Chair. Thank you.
Thank you, Dr. Vuyo. Can I then get Karina, Andre, and the rest of the other execs to respond, please, to the questions that arose?
Thank you, Chair. I'll proceed with the ones that I can address. So the first one is in relation to the difference between the reserve ratio for 2025 and 2026. So the committee would have noted that at the end of 2025, we had a 24.7% reserve ratio, and that has dropped to 22%. So it's a consequence of two main elements. The first is in how the formula is applied. So the formula uses your expected contributions for the full year. So when at the end of the year you move into January, which is our first month of our new financial year, the formula requires us to indicate what the expected contributions for the full year is. And that is then applied to your accumulated reserves. So automatically, just because of the formula, there is a drop in the percentage. The second component, which is important, is seasonality in our environment. So typically the scheme would have better and worse months during the course of the year, particularly winter months are tend to be more ill, and our claims are typically higher. So those are the two main components that affect the percentage that is calculated. In terms of the actuarial increases going forward, so those are based essentially on healthcare inflation as a minimum, in order for the scheme to make sure that we can pay providers and we can ensure members get the cover that they need. The component that is allocated to reserve building is anything between a 0.2 to a 0.4% on contributions. The question around low-income members and affordability. So the Tanzanite 1 option was created specifically for low-income earners. We did see some abuse in terms of that option over the last couple of financial years, and therefore the adjustment we made to the higher salary bands on this option in particular to remove these high income earners from this option, which was created for low income earners, so that the option remains affordable. In addition, those level 1 to 5s, or now level 2 to 6, I suppose, are fully subsidized if they do join the Tanzanite 1 option. So there's no cost for the employee to belong to that option. In terms of how do we justify the increases in light of our mandate? So in terms of the approach, it is a balancing approach between various components that affect the overall decision on a contribution increase. Of course, the most important one is affordability that we try and measure. The reserve requirements in terms of the law that we have to uphold. Making sure that we don't deny healthcare to our members. And then, of course, the fact that we are dealing with an aging scheme and a worsening risk profile, as one would imagine after 20 years, the membership has aged. I think the last one from my side, Chair, was in terms of how would we ensure that reserve levels return to 25% or are maintained without substantially increasing contributions. So these are the areas where we identify specific intervention into the claims area and into the fraud, waste and abuse area. And those are really the levers we have to pull to make sure that we can introduce lower contributions without affecting members' affordability by just increasing contributions to maintain reserves. Thank you, Chair.
Thank you,
Thank you,
Chair.
Andre, please come on board.
Thank you, Chair. On the fraud, waste and abuse side, the first question around AI tools. So at the moment, the scheme uses in-house developed algorithms to detect fraud, waste and abuse. I would put that at a medium level of intelligence or artificial intelligence, and really what we are looking for is a much a more sophisticated way of detecting fraud, waste and abuse based on standard tests and algorithms that we can implement. The other method, of course, is not AI at all, and it relies quite a bit on whistleblower reports that we have received. Chair, then the other three questions I will hand over to Mr. Ishmael Mugabe to deal with. Thank you.
Ishmael?
Thank you, Dr. Tutu. Greetings to the chairperson and the portfolio committee members. I will address the issue around the member collusion. When members become implicated, it is really a single category. So in practice, we see a mixture of maybe the first one is knowingly participating. There's this instances where a member knowingly benefits from an improper arrangement between himself and a practitioner. The other one is more of a provider influence, where members really on a provider's guidance and do not appreciate the implication of what they are agreeing to. And the last one is just mainly related to misunderstanding, where members do not realize that confirming inaccurate services or accepting, substituting services could contribute to fraud, waste, and abuse. And we rely mainly on data, which also give us indications and trends where we are able to can detect if there is collusion between a practitioner and a provider.
Sometimes you look at one member basically and the whole family on a frequent basis visiting one particular practitioner. Those are things that the data can show us, and we will act on that and make the necessary inquiries. The other part, which was also raised by Honourable Member Dr. Klape, in terms of the distinction that GEMS make in terms of fraud, waste, and abuse, we are making that distinction, and it is contained in the recently even adopted fraud, waste, and abuse policy, which the scheme and the board has recently approved. A distinction is definitely made. Fraud matters are definitely reported to the South African Police Services. Waste and abuse matters are reported to the professional bodies, because most of them deal with unethical conduct. That distinction is made. And additionally, we have included the element of error because of there is also the practitioners voice this, that we have to appreciate that some conduct result in error, and that distinction is definitely made. And in terms of whistleblower protection, we do have also an anonymous hotline number which members can use, and that hotline allows for free is a toll-free number which even allows for callback services where members make those reports. And I can indicate around 70% of GEMS investigation emanates from members utilizing the hotline, and anonymity is definitely protected in that respect. And just the last one, basically, in terms of the core drivers of fraud, waste, and abuse, as we have demonstrated, and we can even give a report around this. We do see an issue of a syndicated fraud, waste, and abuse, where practitioners also collude with members, and I'm glad Honourable Member has raised this issue of collusion. The other part, which is more probably practitioner related, we are seeing also an emergence of touting that is happening, where members where wellness days are used to entice members to receive certain gifts, and where those claims, which are supposed to have been screening services, we see claims being submitted for those screening services, and members not being aware that they're going to be charged just to queuing for gifts that they are receiving at those events. But we are seeing those are emerging risks which we are addressing. Thank you, Chair, Honourable Chair. Thank you.
Thank you. Can I ask that we please conclude?
Thank you, Chair. I don't know if we can carry on, Chair.
Yes, we just be mindful that we have got 7 minutes left to 1 o'clock. So if you can just conclude with your final remarks, I would appreciate that.
Chair, thank you very much for giving us an opportunity to present and also respond to the questions that the members have actually raised. We truly appreciate. And Chairperson, if there's anything that hasn't been answered or responded to due to the time, we can provide that in writing. I will hand back to you, Chairperson. Thank you.
Thank you very much. That's much appreciated, Honourable Pelisa, and I will give you an opportunity. You want a second bite of the cherry? Please proceed.
Thank you very much, Chairperson. No, Chair. Maybe just to also reference to the first speaker that was responding on behalf of GEMS. There's no way you can say that people are appointed in these positions and there's nothing GEMS can do. Because are you trying to tell me that if a person is a rapist or a bank robber, and is appointed, there's nothing that GEMS can do about it? It doesn't hold. that argument really doesn't hold. But what I wanted to address, Chair, is what the DM said, to say there should be a meeting between you and Honorable Faith Mutambi and herself. And I'm saying I don't agree, because then it can be a joint committee meeting. Because, for instance, Chair, when you were giving your remarks after the presentation of GEMS, you were applauding them. But most members of this committee were actually seeing that there's something wrong with GEMS. So I'm actually not comfortable that that meeting takes place outside the members of this committee, because we will be misrepresented. If there's any meeting that needs to take...
Honorable member, if apologies for interrupting you, but I think you misunderstood. The suggestion was that it is a meeting between the committees, not a meeting between the chairpersons, and not that committee members are excluded in any way. That was not the intention.
If that's the case, I take it, Chair, and I apologize. I didn't get that. I thought it was just the chairpersons and the DM. I just wanted to raise that concern. But if we're included, then I don't have a problem. Thanks, Chair.
Thank you, member. Honorable Mutami, you've got the you can have the floor. I see your hand.
Thank you so much, Chair. That's the other clarity I wanted to clear, to say it's not us as chairperson. It's going to be a joint committee meeting with all of us as members of parliament. Secondly, I think the issue that the chairperson of the board is committed to write our responses, because I still think some of my questions as raised, they are not adequately responded. Secondly, I wanted to concur with the previous speaker on the response by the head of legal. I think I want to emphasize this, Chair, so that this thing must be heard clearly. Yes, this issue of public servants serving in the board is true, it was there. And as the Deputy Minister has said, the institutional memory is clear that public servants in the past who used to serve, they were not paid sitting up board allowances like what is happening currently now. So it will be important for us to be given the board decision that made them to, more so like what we have indicated, this is a public sector medical scheme, and public servants are governed by the Public Service Prescripts and Public Service Act and regulation. It's very clear. So a normal sitting legal advisor of the GEMS, because you see, GEMS, yes, it's a medical aid scheme, but it's a medical scheme that is meant for public servants, though it's a closed schemes and all this other stuff. Due diligence could have dictated to say, no, these are public servants. And in the past, it's on record. There were public servants who previously sat in the board who were never paid the sitting allowance like what is currently happening. So that board decision as to what informed it as part of the written responses, I think it will assist us, because it can't be right. Public servants are governed by public service prescripts, and as this portfolio committee, I think you are best placed on that. So if somebody is doing other remunerative work, there are permissions that has to be sought. I'm glad that the Deputy Minister is committed that she's going to look at the matter. But that response, Chairperson, I think we needed to be taken serious as members of parliament. It was very disturbing. Thanks for the opportunity.
Yes, thank you, Chairperson Mutami. I think that the meeting we will request between your committee, our committee, and the Standing Committee on Finance, we can discuss also perhaps sending our queries and our questions to GEMS before they appear before that combined committee, so that they are also prepared to exactly speak on these difficult questions. And I would just like to say that I think we must ask to see what is normal in other boards where public servants also meet. Are they paid sitting allowances or not? Is it considered double dipping? Is it considered legal? Just make sure that we understand the process. Honorable Malinga, I will give you the last opportunity before we close.
Thank you, Chair. Just a few seconds. I think, Chair, let's try and invite the organized labor, the people that are dealing with these issues of GEMS on a daily basis, so that we'll have all relevant information Thank you.
Thank you very much. I will consult with the other chairpersons. I don't think it's a bad idea, because we have seen organized labor also attending and have their concerns about the issue as well. Members, that brings us to 1 o'clock. Thank you for your participation in the meeting. Thank you for GEMS for their participation in the meeting, Deputy Minister, Chairperson Mutambi, all other members of the committee. I hope we all have a successful afternoon, and we will obviously see each other virtually on the plenary. Honorable Langa, I see your hand just went up. Do you have a last procedural matter before I close?
No, Chair, apologies. I just wanted to check, Chair. Maybe the committee has already addressed, or dealt with the program for the next term. So I thought maybe because we'll be going to recess now. So if we haven't done it, I wanted to check when is the committee going to have a look at it. Apologies if the committee has dealt with the Chair. Thank you.
No problem, Honorable Langa. It's a fair question. So usually what we do is the management committee of the committee. So it's myself and Honorable Kaba. We sit down with the staff and then we come up with a draft program. Usually in our constituency break for the next term, and then we communicate it to the members after that. So you will receive a program in the next few weeks before we return to Parliament. We obviously have great regard that members need to plan their travels as well. So you will receive that. Thank you very much, members. I hope everybody has a great day. And with that, the meeting is adjourned. Thank you.
Thank you, Chairperson, and thank you to all the members of Parliament and Deputy Minister, and also the Chairperson of the Portfolio Committee on Health. Thank you.